Good afternoon. I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I'm delighted to welcome you to our April webinar, Primary Care, More of It Bends the Cost Curve for ACOs. So we've put the punchline in the headline, but we will unpack what that means over the course of the next hour. For those of you who may not know the Primary Care Collaborative, we are a DC-based membership organization of 70 different organizations from every sector in healthcare. And what unites our varied members is a commitment to strengthening primary care as the foundation of a high-performing health system. Today on our program, we're going to discuss a report that analyzes data from the MSSP program and consider its implications for policy and payment, model design, and the like. Let me begin also with a couple of housekeeping items. All of our webinars are recorded and they are on our web within 48 hours on our website. You can, and we encourage you to put questions into the question place on the webinar, and we will reserve 10 minutes at the end of our hour together to review these questions and answer as many of them as we can. That is it for housekeeping. Now let me just provide a little bit of context around this report. For those of you who follow our work, this will be no surprise to you that the Primary Care Collaborative has really adopted the National Academy of Science, Engineering, and Medicine report as a very important blueprint for our work in the payment arena. The report calls for both public and private payers to move primary care to a hybrid payment. That is a blend of a prospective payment and fee for service, and also to invest through that payment model more dollars into primary care so that it can deliver on what we know it can deliver on, and all the evidence shows us better population health outcomes, more equity, and yes, even begin to bend the cost curve. We're excited about the recommendations in the context of the recent data and analysis in this report from Wakely, which shows that Medicare's largest alternative payment model program, the Medicare Shared Savings Program, which is the ACO program, shows that when you have more primary care in MSSP ACOs and more provision of E&M services, you get better performance results. We're excited to have the actuaries come and unpack these results for us from Wakely, to have a researcher from the Duke Margolis Center put those results in a broader context, and also to hear from a leader from the American Academy of Family Physicians, who has recently released some guiding principles and priorities for primary care payment reform, and reflect on what these results might mean for AAFP's agenda. One note about the Wakely report: it came out in September, but didn't get a lot of attention at the time. In fact, in my travels talking to policymakers, many of them really didn't know about it. So we're very excited to bring you these results, and we encourage researchers out there to mine the MSSP data so that we can truly understand what contributes to high performance of these ACOs. Now let me introduce the panelists. And so please, panelists, join me by turning on your cameras. First, our two panelists from Wakely. Hunter Schuweil joined Wakely in May of 2021, and his primary focus is working with provider organizations on their value-based program strategies and supporting their operations to drive success into alternative payment models. He also works with health plans as they move to alternative payment models, and he works both with government programs such as MSSP and various CMMI models, and also private payer alternative payment models. Welcome to you, Hunter. Next, his partner in crime, Brad Hayward, has been with Wakely for some time now. Wakely Consulting Group is an HMA company, and he's been there for 5 years. He's been involved in a wide variety of areas within healthcare actuarial consulting, Medicaid managed care organizations, doing rate review, trend analysis, lapse rate analysis, and risk adjustment. And he's also more recently become a Medicare ACO expert and helped many ACOs as they calculate potential shared savings and consider various CMMI programs. Next up, Rob Saunders. He's Senior Research Director, Healthcare Transformation at Duke Margolis. In this role, he directs a portfolio of payment and delivery reform initiatives, which focus on ACOs, alternative payment models for specialty care, new payment and delivery approaches for serious illness care, and translating evidence to policy relevant options. Rob and I have actually overlapped in 2 organizations, one at the National Quality Forum, where he was senior director and then senior advisor to the president. Prior to that, he was senior program officer at the Institute of Medicine, and even did a stint on the Hill in legislative affairs for Representative Rush Holt. Finally, last but not least, Karen Johnson. She's Vice President, Practice Advancement, American Academy of Physicians. She's an accomplished leader with experience that spans many different sectors. She's worked with employers, plans, providers, and health systems. And each of these perspectives contributes to her work as a translator, bridge builder, and change agent. Her long-standing personal mission is to make healthcare work better for people at a cost they can afford, and she sees primary care as foundational to making that happen. At AAFP, Karen's team includes the Center for Payment Innovation, and we're going to hear more about that through her remarks today. So let me first ask the Wakely team to share their analysis of the 2021 MSSP results, and then we'll have an opportunity for Karen and Rob to ask any clarifying questions about the results or about the methods and the like, and then we'll have a conversation about the implications. So let me turn it over to our Wakely team.
Great, thank you, Anne. Now, if we can jump to the next slide, I'm going to start off with a little background into what the actual study was. First off, I'll start with the bottom right chart. Essentially, what we see and what drove us to perform the study is exactly what we see in this chart of savings as early as 2013 that were achieved within the MSSP ACO program. But over the years, as each performance year moved on, we see almost an exponential growth in savings from more of a minimal 2013 savings to an exponential $4 billion gross savings generated through the MSSP ACO program. Now, we understand that the program has grown significantly with many more ACOs joining year over year, but this still led us to question and form the basis of our analysis around what are the main factors that are driving these savings. With these increased savings, with the exponential growth, what characteristics and what are the ACOs doing that are driving these increased savings? With that, we deployed our Wakely risk insight analysis, or we call it the WRI. It's an analysis that we've done for more than a decade across different lines of business, but more recently we adapted for the MSSP program. And really the main idea is to drive insights or review the data to understand what are the key profitability drivers that are driving the success within the program. So really, the 2 main goals, or what we were trying to do, was first, we wanted to review the correlation between savings and various ACO characteristics. This means we wanted to look at, obviously the title of this conversation, PCP percentage of the actual participant list, or a high versus low revenue ACOs, different makeups, and all other different kinds of characteristics of the ACOs, and see if there were any correlation with the savings that they achieved. The second piece was to look at the gross savings as it related to actions taken by ACOs. So moving beyond just the characteristics, we wanted to understand if those with higher risk scores or higher risk score growth or different expenditures were resulting in higher savings or lower savings, and maybe what the relationship was. So with these two goals in mind, we put together our WRI analysis using the publicly available data that Anne has been referencing. We went back multiple years and reviewed all the different characteristics, different splits of the data, and different analyses to better understand these two goals. And with that background, I'll turn it over to Hunter to give you the quick overview and results of our analysis.
Thank you, Brad. Can you go ahead and advance the slide, please? So I'm going to quickly run through some of the key takeaways of our study. As Brad mentioned, we really wanted to look at a couple of different buckets of ACO characteristics and some of the actions that they were driving within their ACO. So we looked at 6 main buckets. One, how was the ACO comprised? What were some of the population characteristics, some of the other programmatic decisions that they have made? Did they elect certain benefit enhancements? What type of risk were they taking? We looked at their duration or their experience in the program. We looked at the presence of a facility or hospital as a participant within their network. And then we looked at quality as well. And so our ultimate goal was to really look at which of these characteristics were most highly correlated with gross savings performance for ACOs. And I think the main 2 takeaways and the 2 key findings that I think the audience will find insightful are that we found a high correlation with ACOs that had a higher percentage of their participant roster being made up of primary care providers. And then we also saw a high correlation with performance where those ACOs that had a high percentage of their evaluation and management visits with primary care providers versus specialists or nurse practitioners. Additionally, there were a couple of other key findings as well. We looked at ACOs and split them into those that were taking downside risks that were in versus those that were in upside only tracks. And we found that those ACOs that took downside risks saw greater success within the program. Additionally, there's been some nomenclature evolution over time in the MSSP program. Historically, there was labeling of physician-led ACOs versus hospital-led ACOs. And now there's a status of low revenue versus high revenue ACOs. So in our study, we looked at low revenue versus high revenue ACOs, and we saw that low revenue ACOs saw greater success in the program compared to high revenue ACOs. Now, there's not an exact one-to-one match between low revenue ACOs and physician-led ACOs, but predominantly your low revenue ACOs are those made up of physicians and usually don't include a facility or a hospital partner within that accountable care organization. And then when you look at also the fact that when you have a hospital or facility presence within your ACO, there is also a high correlation where those without hospital presence saw a higher level of success within the program. And then another thing to mention is that with low revenue ACOs, while we did see greater program success, we saw a wider array of variation in the performance for those ACOs. And then finally, a couple of interesting areas where we didn't see high correlation between the ACO characteristic and their performance was in the quality scores for the ACO. We also looked at the use of the 3-day SNF waiver and we didn't see that groups or ACOs using that benefit enhancement saw greater success in the program than those that weren't. And then we looked at geography as well as population morbidity, and I'll say our geography was fairly broad. We split the country into 4 main regions just due to sample sizing. And so I think potentially if you were to look at more minute geographic boundaries, there may be some more interesting insights than what we found here. But then we also found that population morbidity, so those populations with higher risk adjusted experience didn't see greater success in the program either. So I think the main takeaway for today is that ACOs that focused on emphasizing their participants in their ACO around primary care providers, and the ACOs that tried to generate engagement with their patient panels with their primary care providers saw great success in the program.
Thank you so much, Hunter and Brad. Terrific. And now I think you can take the slides down if you would, Edward. First, I wanted to ask Rob and Karen if they had any clarifying questions about the results or about the methods. Let's sort of get that on the table first.
I have one quick question. I thought it was interesting that dip in performance in the early years, and I wondered if that was similar for all ACOs, whether they eventually led to greater success at shared savings or not.
So one of the things we did look at was the duration, and we did see that over time as ACOs participated in the program longer, they saw greater success. But when then they started a new agreement period, they saw a drop in success, and a lot of that is due to the fact that their baseline or their benchmark is derived based on that most recent success they had in the program. So some of the things that folks have seen come out in 2024 for the program, some of the changes were really to hit at that particular observation that's been seen over time.
Super. Well, if there aren't any more clarifying questions, you've done a heck of a job in 3 slides presenting your results. So congratulations. So I'd love Karen and Rob to just reflect on what they think might be happening, either at the practice level or actually at the sharp end of care that could be driving these findings. I mean, we know that largely primary care physicians and other clinicians in MSSP are paid fee-for-service, so they're still on that regular fee-for-service chassis. So what do you think may be going on to drive these kinds of results?
So I'll jump in first there. We're having a lot of conversation with our members about what's happening in those practices that have really achieved success, whether it's in an ACO model or otherwise, some form of value-based payment. But first, I'd just like to say thank you to Wakely for doing the report and for making it so broadly available, and for PCC for lifting it up, because there are way too many conversations that we go into with key stakeholders outside of our tight little policy circles that are not aware of these data points. And so that gives us real tools to go out and talk to others about why investing in primary care is really important and will eventually really reap the benefits that we know that the literature suggests it will. So thank you for that. And in the conversations that we're having with our members who are really in practices that say, yes, value-based care and payment are really working well for us, which is not what we hear from everyone. I think we'll talk about a little bit more about that later. But what we hear is probably a lot of things, but there are 3 themes that are coming out of this. One is teams, another is data, and the third is time. So I think teams are just a really common theme. You cannot do this alone. And so whether it's a core team that's everyone operating at the top of their license, including MAs, or it's a fully integrated team with social workers and community health workers and pharmacists and behavioral health practitioners, teams are a really important central theme. and making those teams sort of cohesive and work well together, I think is a really important piece of this. In terms of the data, we know that practices, physicians, care teams need full information to take good care of patients at the point of care. And while we're still struggling a bit with that sort of vision of a patient-centered, fully interoperable healthcare information ecosystem, we are making some strides in sharing those kinds of information that are really important for just basic care of patients. However, under value-based payment and care expectations, we know that the data needs and the information needs are much broader. We hear physicians talk about not just what they need at point of care, but how important those in-between spaces are, those times when the patient's not on your schedule, and how do you get visibility into where they are and what's happening with them? Are they showing up in the ED? Are they having recurring admissions that maybe you don't know about on a timely basis? So there's those kinds of data and information needs, but I think also just how are we doing? You know, too often the information lags around what does our performance look like. So timely, I think successful ACOs have really cracked that nut, and they're identifying how to bring that information to care teams and really support their success, including like how are we doing against those measures that we've agreed to of success under our value-based contracts, and hopefully early enough to make course corrections. And so the last thing I mentioned is time, and time has obviously multidimensional, but I think time here, it's not terribly surprising to us that you see over time those practices who are having increased success over time as opposed to early in the program, especially under a shared savings program model where those investments do not come back to you until after the fact and sometimes far down the road. So again, that dip in performance and then that increase over time, not terribly surprising. And it's one of the reasons why in those principles that Anne referenced that the AFP membership has adopted its value-based payment policy, really starting with population-based payments as one of the important mechanisms to act as a change agent and really drive change is really, really super important. So I know we'll talk a bit more about payment later, so I'll leave it there and turn to Rob.
Thanks, Karen. And maybe I'll pick up on starting on the time aspect. And you know, when we've done our research in the past, looking at ACOs, both looking at the data as well as interviewing ACOs to understand their performance, time comes up, very regularly. One of the big challenges is that you're asking, a practice and asking an entire organization to change a lot of the way that they've been delivering care. And it's hard to flip a switch and say, well, on December 31st, we are providing care this way. And January 1st, we're changing our team structure, our workflows, our data systems, all to do it a new way. And our rule of thumb that we've heard out there is it takes about 3 years to make that switch, for most ACOs. That year one is, you're getting this new claims data from CMS, which is great, and you've never seen before. Where are your patients going for care? Or which patients are going to the emergency room? Which patients are in the hospital? How do we help understand that patient journey? But in year one, you're just hopeful that you can open the data file, and in year two, you really hope to understand what's happening and really hope to start crafting interventions. In year three, you can start really implementing things and start to see the fruits of your labor. But that takes at least 3 years to really start from the time you enter the ACO to you've made these very large, dramatic care improvements. So I want to echo the point that Karen made on time. I'd add sort of 3 more points here. One of the points to think about is, since the data does lag a bit, we're talking about 2021 data. And it's important to think, while in 2023, the world looks a little bit different, in 2021, the world of primary care was still under some considerable stress. Not that it's not under stress now, but it was under a more heightened set of stress in 2021. And some of the things that we heard from ACOs, especially primary care ACOs, is even though they were being paid a fee-for-service arrangement, any amount of shared savings that they had, any type of flexible funding that they had, was really helpful for staying afloat. I mean, that was very true in 2020, where you had dramatic drops in in-person visits, you had dramatic revenue losses, and many independent primary care practices were, having to shutter their doors, having to furlough or even lay off staff. Some were closing altogether. And so do want to note that, we are talking a little bit about what was happening during COVID times, and it's actually quite impressive that we were seeing positive results even during 2021, even during pretty challenging circumstances. So that's one point here. A second point I think I wanted to flag is just the heterogeneity of ACOs, that we will have some ACOs that are, say, confederations of independent primary care, oftentimes working with a third party, and there's several third parties out there, but who are really helping to keep those primary care practices independent, helping them to change their models. And for those particular types of ACOs, to Ann's point, they are really benefiting from any type of flexible payment arrangement, even if they're being paid for fee for service overall. Having that type of flexible funding arrangement can really help them stay afloat and help them add team members in a way that they just couldn't before, and is a helpful transition point to the future. And then one last point, we at Duke have also done research using the public data. A lot of the comparisons we're doing when we're trying to figure out savings there is really a comparison to an administrative benchmark, that's been set based off history, based off the other practices in the region. And that's why you might see some interesting things happening, say, for instance, when we rebase that benchmark every 3 years or at the start of a new contract period. If you actually think about comparing true savings, which would be, what would happen if, say, this ACO program didn't exist at all, you often see even bigger amounts of savings. And there's some researchers out there who have done that type of very careful, very lengthy types of research that compare to what would happen if, say, the MSSP didn't exist at all. So if anything, we're actually underestimating what the savings might look like, and we might be able to see even greater savings from that perspective. So I want to just emphasize the time, the fact that we are still thinking about how the world looks during COVID periods and the heterogeneity of those ACOs as well. But back to you, Ann, to continue the conversation.
Thank you so much. And interesting for you to bring us that other overlay of context, Rob, that many of the results that we're looking at did happen during a time of high stress for everyone across the country, our patients, and also primary care. And so it really will be interesting to see what the results look like as on a going forward basis. I think the other thing, and some of the other things that you all mentioned, I wonder if they are researchable, and I don't know enough about the MSSP data set to know. Karen mentioned that her members tell her that they find, when they have a team, they're better able to meet the performance metrics. Is there any way to look at the MSSP ACOs based on, who's in their practice and try to discern if that is a factor? Brad Hunter?
I can take that one, Brad.
Yep.
But unfortunately, the public data sits at a fairly high level. The level of granularity that's released publicly about the characteristics of ACOs is, what you see is about the most level of granularity that you can get. I think there's been a lot of push for CMS and CMMI to release more granular information so that more studies like this can be done across the industry to better understand things. But today, that's definitely a current limitation.
Anybody want to pile on that question or have any further comments? Karen, looks like you're about to speak.
Like, the whole team question and how it works feels like a really good qualitative study. I don't think there's good data out there to tell us what the structure of specific practices looks like. But I want to also go back to something Rob said about the ACOs themselves and the independent practices, because I think that we were sort of looking for members to talk to who are in those practices that were really having good success under value-based payment. It was hard not to find someone who was working with one of the aggregator enabler organizations that's really facilitating their support. So I think in terms of like ACO participation in the value-based world, that's almost an essential for an independent practice that's out there, and so grateful for the ones that are doing that really very good work and important work. But it's not the only way to participate in value-based payment. So there's other, I think that's the genesis of this conversation today, and what's inherent in the AFP policy around, or the principles around value-based payment, is that population-based payment, a more upfront, predictable, revenue stream, is the only way to get us to that place where you're going to be able to do those sort of upfront investments in the teams and the technology that you need. But I think it does sort of send a really strong message that going it alone as an independent practice it's a tough road to hoe.
Well, you've actually nicely set up my next question, Karen, because let's just remember these MSSP ACOs were able to achieve these results largely without prospective payment. So they may have built out teams, but they may not have been able to benefit from having a prospective payment that gave them that knowledge and confidence that they knew what their revenue was going to be in the month ahead, so they could actually hire someone, right? And so we're seeing these results without that prospective payment. Imagine that we were changing the way primary care was paid within MSSP. That moved us towards that hybrid payment that I talked about at the top of the hour. You could surmise that we would see even better results if that prospective, at least part of the payment was prospective, freeing up the primary care clinicians to practice in ways that they could more customize what the patient needed. Some may need an in-person long visit, others it's going to be completely satisfactory for the patient and for the primary care clinician if it's a quick video conference or an encounter through the patient portal. So, this notion of freeing the primary care clinicians up to practice in a way that really can be customized to patient need, I'm wondering if folks would reflect on that and what they think could be possible if we move to a hybrid payment option within MSSP.
And maybe I'll start on this one. So I do want to call out our friends at CMS who've made a number of strides in this direction. So at the beginning of the Medicare Shared Savings Program, there was a program called the Advanced Investment Model, which was designed to give some level of upfront payment to help those groups who were just getting started and down that value-based journey. It showed really positive results, and then finished as and sort of a sunset for a while. Starting very recently, CMS has brought back those principles into the Medicare Shared Savings Program. So there are some opportunities now, especially for those practices, as Brad and Hunter noted, more of those low revenue, which are supposed to be surrogates for physician-led or independent primary care practice-led, ACOs, to start getting some level of upfront payments. On the ACO REACH side, which is a more advanced ACO model, or tends to have a little bit higher risk than, say, the Medicare Shared Savings Program, that program, in addition to having some upfront capital and some upfront funding abilities, also does have some level of ability to get more primary care type capitation, as well as some level of total capitation. And so there are some models that CMS is rolling out. Now, as you know, Dan, there's always more we could be doing here, and we could be making a lot more progress, but do want to recognize CMS for having made some adjustments quite recently to get to that upfront capital point, because that's been a real sore spot we've heard from our independent physician, independent primary care practice perspective, that they'd love to get involved, but they just don't have that upfront capital lying around to help them make the investments in new team members, new data systems, new workflows that you really need to be successful here.
Yeah, I would add to what Rob is saying and echo his comments and his appreciation for those additions to those programs. But I think also thinking about sort of who can invest, The independent physicians are the ones who really benefit from that. The larger systems that are participating, generally don't need that level of upfront investment. And I think one of the challenges that we see and hear about, and that is really fundamental to this conversation as well, whether you're an independent practice in an ACO or employed in a large organization, that population-based payments intended for primary care should always go to primary care. And I think that, those who are supporting them, ACOs, for example, who are providing shared services, I think, they should be able to work out their arrangement and strike a fair deal for what the ACO is providing. But fundamentally, those payments should go to primary care to support the infrastructure, the teams, the technology, and it should be provided to them in a way that gives them the autonomy and the flexibility to create the practice that meets them as clinicians, as well as their patients and their specific needs of their populations. And so inherent in any conversation, I think about, regardless of whether it's fee-for-service or population-based payment, that's sort of a tenet and a principle that's actually embedded in the AAFP guiding principles, not surprisingly, that you would hear us say that. But it's interesting, we have 6 principles, and the first one, which really talks about the importance of shifting away from fee-for-service toward population-based payments, is the only one that I call a twofer. We sort of slid into that one also, this really important point that if it's a primary care payment, whether it's fee-for-service or population-based, it should go to primary care to support the investments that's needed in an area that we know has been woefully under-resourced and supported for many years. So that's just, it's an important aspect of this conversation, but I think the more important part is how do we get those population-based payments in place and scaled throughout many, many programs. We've seen strides in Comprehensive Care Plus and Primary Care First and other programs, and hope to see those continue, and I know that they will. And we're seeing more commercial uptake in that as well. Had some conversations today about some Medicaid agencies and states that are really leaning into population-based payment, and how do we make that work? So I think it's just logical that we would be having this conversation about the context of that in an ACO.
Thanks so much, Karen and Rob. And I do want to acknowledge that CMS has recognized the challenges, particularly for primary care practices that want to form ACOs and need that upfront capital. And so that's incredibly helpful. This notion of making sure that new investment gets to primary care is absolutely essential to the Primary Care Collaborative, but also was one of the recommendations in the NASM report. For those of you who missed the primary care scorecard that came out in March, we've actually seen a decline in the percentage of dollars that are being spent on primary care as a percentage of total cost of care. So we look to primary care to help address some of the nation's most pressing health problems, whether it's obesity, hypertension, behavioral health, inequities in care, et cetera. And yet our expenditures don't reflect what we're asking of primary care or what we say we value. We value addressing these problems that are really afflicting the nation, and yet our budgets, our financing does not reflect those values. So we've really got to further align what we say we want our health system to address in terms of the nation's health, with the finances to do that. And I am absolutely agree with you, Karen, that as we work on these models, whether it's at CMMI or CMS or in the commercial sector, we have to make sure that the dollars actually get to primary care, because sometimes when they are filtered through a health system or an ACO, they're not reaching primary care. And we cannot afford to keep disinvesting or not providing adequate investment in primary care. The platform can't do all that we know it can do without that level of investment.
And if I may, can I add one comment to that?
Sure, of course.
Yeah, so it's so interesting, you know, we're having multiple conversations about messaging around value-based payment and care, and how there are really two sides to that coin. One is that value-based payment and doing value-based care under value-based payment is burdensome and hard. And that's because we know a lot of it is really just fee for service with some quality measures tacked on. And so I think one of the things, and I know we're talking to an audience of believers and champions and leaders in this space, I think it's really important to be very careful about the messaging that when it comes to primary care, when value-based payment is done right, which really leads with upfront investment, ideally through population-based payments, it can really lead to some really great things. It provides, like I said, we've talked about the flexibility to invest in teams, technology, and infrastructure, but I just want to make sure that we are all sort of really cognizant that you cannot paint value-based payment with a single brush. The conversation has to be much deeper and it has to be much more nuanced.
I think if we were talking about value-based payment for a pediatric practice, it would look very different than for adult medicine. I mean, I think, you know, we really have to understand, you know, the population that's being served by the particular model, the kind of practice, who's in the marketplace in terms of the sorts of professionals that could be on that team. I could not agree with you more, Karen. But the other thing I think we don't want to talk about investment in the context of you know, more dollars, and our healthcare system just keeps growing and growing and growing. I mean, I think what's interesting about what we're talking about today is that we're within a total cost of care model, and so what we've seen is primary care is delivering savings, and this is when they're still in fee for service. So imagine you know, some of the evidence we have from organizations that are in prospective payment or even in, you know, primary care cap or even total cap arrangements, they're seeing even more savings. So try to imagine CMS, if you're listening out there, what it could look like. And this is something that we are proposing through our Better Health Now campaign to move to a hybrid payment option within the MSSP program. And we agree that we need a lot of solutions. This could perhaps be an additional solution to what we already have in the toolbox to move this conversation forward. Rob, what can you tell us from other research that exists about the role of primary care and performance of ACOs? I'm wondering if you can, you know, this finding is very important, but it's not the only look at this particular issue, and maybe you could provide that broader context.
Sure, happy to. And maybe building on one of the points that Karen raised as well is we also recognize that primary care is very heterogeneous, that, you know, there is the maybe very more common model, although common models of primary care are changing very rapidly, of, you know, an outpatient independent primary care practice. But there's a number of primary care that have focused on very different populations. You know, there's home-based primary care, especially for a homebound or more serious illness population. There's a variety of other primary care type practices out there, each of which are going to have a little bit different approach to, you know, an effect on to total cost of care. So I think that's one point just to start with. And then the other point really to raise here and to your question is in all ACO program, primary care is the group who helps determine what population is being served. That, you know, it's a primary care practice or primary care visits that determine what patients are attributed. And so for all types of ACOs, whether those are, you know, independent practices, whether that's a multi-specialty group, whether that's a hospital group or some other types of configuration, primary care is the front line of the ACO, and that is the group who determine who's coming into the model, as well as for all those quality measures that were pointed out. Most of those are measures that are really indicative of primary care practice, of, you know, managing chronic condition, prevention, and so primary care is the backbone for most of these types of ACO models, and is needed regardless of who the other players in the ACO might be.
Thanks so much, Rob. Your just so you know, your audio is a little bit wonky. So I don't know if maybe you get closer to the mic or refresh. I'm not sure which, but thanks. We've got now some time for questions from those of you in the audience, and also we want to continue the conversation with everyone here. Thanks, and you can also now put down this, the slides. The first question is for either Brad or Hunter. Wondering if you did a comparative analysis of performance in hospital employed PCPs versus independent PCPs.
Brad, you want to start and I'll add further commentary?
Yeah, I want to say, most of our analysis was based upon what we've been discussing, right? Looking at the PCP buildup of your actual ACO, low versus high revenue. Please correct me if I'm wrong, Hunter. I don't think we dove into the actual IPA buildup versus facilities. But yeah, any further commentary would be helpful, Hunter.
Yeah, we weren't able to get into the independent versus employed in the data set.
Yeah. Given the granularity of the public data, some more detailed analyses get a bit more tricky to get into. It really depends on the granularity of the data that CMS provides.
But I think Rob touched on this earlier, that the low revenue definition tends to lean heavily toward independent practice versus hospital employed. And I think you're finding around whether there's a facility in the mix or not. Also, we can make some sort of educated sort of, I don't hate to say guess or assumption, but, I think we can say, yeah, we think there's a difference.
There's certainly an inherent tension there, right? If you're an independent physician that has, loose or no affiliation with the healthcare system, you have all the incentive in the world to think about the best way to reduce appropriate, avoidable hospitalizations as much as you can. Whereas if you're a part of a system, you're going to have those inherent tensions around, well, maybe we're going to try and focus our resources in reducing, avoidable utilization or waste outside of the walls of our health system. And so while there may be utilization reduction, maybe it comes in the form of other areas outside of, acute inpatient spend.
Great. Here's another question that is for our colleagues from Wakely. It's a question about the longer participation history where you see ACOs do better over time. Michelle Medina wondered if that may be also due to patient retention. So this ongoing relationship could also be a part of what is, a contributor to the success of the ACO. I'm wondering if you can comment on that, Hunter or Brad.
Yeah, I can jump in real quick. So the data doesn't allow us to look at the retention by ACOs, but speaking anecdotally, we do a study on the Medicare Advantage population, so not ACO, but from the MA world using the same analysis, we do look at it at a member level. And one of the big findings we had is the retention. So if a member is with the MA plan for more than 1 year, over the years, the plan has had time to work with the member or provide that type of care coordination, which essentially is a big profit driver from that study. So while the ACO population might be slightly different, I think the same relationship stands from what we found from the MA study, that the longer the members are with the plans, the stickier they are, if you want to call it that, the more ability that the plan or the ACO has to work with those members, that I do believe is driving part of that success. And I believe that was a finding from the MA study we did.
And I think the only
Karen or
thing,
Rob? Oh, go ahead, Hunter. Sorry, you wanted to add something.
I was just going to say, I think the only thing I would add there is churn is definitely an issue in ACOs. You know, just working with our clients, we have groups and ACOs that see, you know, 20+% of their patient population isn't there the next year because of the attribution models and just the broad open network of fee-for-service Medicare. And so some of the things that you can do when you have a population that's retained over multiple years, there's just an inherent struggle of getting patients engaged, hooking them up with the right care management and other types of preventative programs that you're looking to invest in is really difficult when, you know, a quarter of your population that you're trying to focus on is leaving every single year.
And I think
Gotta do
maybe
some work on those attribution models. Sorry. Go ahead, Rob.
Sure. No, and I think maybe taking this to a slight sort of next topic would be, you know, one of the big questions I think for ACOs moving forward, and especially for primary care, is how the ACO model writ large can be useful in addressing inequities in, you know, the patients that are involved in the model, as well as making sure we're bringing in organizations that maybe haven't been as involved. And so, you know, I think that's a big interest of CMS right now, where CMS is really interested in seeing, you know, what patients are currently attributed to the ACO program, but making sure that that, you know, attributed population is representative of the broader Medicare population in terms of sociodemographics and other factors, as well as making sure that we're involving organizations, you know, and different types of primary care, maybe more community health centers, rural health centers and the like, who are seeing populations that maybe have not been part of ACOs in the past. And so, building, I think, on this population question, I think there's a lot that we know that primary care can do to help reduce inequities. There's more that can be done, and you know, I think we need to push primary care and all of our colleagues to see where there's more that could be done here, both in terms of outreach, in terms of management, in terms of outcomes. And so I think that's something where CMS is thinking really long and hard for, you know, making sure that all of the incentive structures are appropriate and also encouraging equity. So for ACO Reach, we saw, you know, different types of benchmark structure to help encourage, you know, new organizations come in who maybe are treating populations that have not been part of ACOs in the past, as well as, you know, where we are measuring data on the outcomes and how well the care quality is for, you know, for different populations to make sure that we have equitable outcomes as well.
Yeah, I'd like to add on here too about continuity. I mean, the evidence around continuity of care and the strength of that in primary care and the correlation of that with, you know, all the other good things, improving health, preventing disease, reversing disease, which avoids the high cost and necessary services that lead to shared savings in an ACO model. You know, it's inevitable that it's important, especially given what Rob said, you know, primary care is the front door to care in any environment, should be, but certainly in an ACO environment. And so there's another question I see here, if you don't mind, Anna, on quality measures and why we don't see greater correlation there. And I'd love to jump in on that one to say, maybe we aren't measuring the right things. And it could be that the measures that we have in place from a quality perspective have become, dare I say, sort of checkbox exercises and data scrambling exercises to make sure we have the data to demonstrate we did the things we were supposed to do. And why we at the Academy are really big advocates for true measures of primary care success, which I do think would be valuable in an ACO context as well. So continuity of care, person-centered primary care measure, which is really a measure of patient experience, which will also lead to greater continuity if that is improved. So I think there's a real big opportunity in that space, and think that that's not surprising. I don't think terribly surprising to us that there was not a strong correlation in the quality piece of this with the overall savings.
Yeah, and I think building on that, Karen, you know, even for the quality measures, there's not a correlation, although the overall quality scores are relatively high. So I think, you know, part of this is the design of the ACO model that, you know, you have to meet that quality gate in order to get shared savings. And right now we're at very high levels for almost all of the quality measures, but 100% agree with you that we could do a lot better on our quality measures to, things that actually are more meaningful to providers and patients and, are helping to drive outcomes as well.
So I can't resist because Rob and I had many debates over the years about quality measures at the National Quality Forum. And, a lot of our primary care measures are, they're condition specific, and, they are not perhaps all that important to the patients. And, they represent, like a narrow slice. Measures, in addition to continuity, measures of comprehensiveness, because we know comprehensive primary care leads to better outcomes, would be very helpful. The Bermuda Triangle of measures, care coordination, is my care getting coordinated and integrated? That's actually, very important to patients, and is what primary care ideally is doing well. So I think we've got a ways to go on the measurement front. I also wanted to mention something that I think in the best cases is happening with primary care, where you have a degree of trust between the patient and the primary care clinician that leads to better health outcomes, because I trust that you're giving me advice about, getting that vaccine or about a particular treatment that you want me to do, because you know me, you know my situation, you know my family, you know my mental health history, etc. And trust leads to not only quote unquote patient compliance, which it's a awful word, but this notion that what the primary care clinician recommends, the patient agrees and moves forward with. But also, so much of what needs to happen is behavior change, and that doesn't happen with. I think it's less likely to happen with a transaction. It really, I think the evidence is increasingly showing that happens not just through data and an app, but when you're in a relationship with someone and can talk through these issues that are very challenging about changing behaviors that can lead to better health. So I just want to thank all of our panelists. It was a fabulous conversation today, and I think we ended on a really important note, which is really about that importance of that relationship and what can we do on the policy front to move primary care into a position to really, better provide the kind of relationship-based care that can lead to better outcomes for patients and for our nation. So thank you so much. And again, we'll have the webinar available within 48 hours. Join us next month. We're going to talk with innovators in the commercial sector, both primary care practices and health plan leaders, about how they're innovating in payment and delivery in the commercial sector. So have a wonderful afternoon.